I think the other point that I wanted to bring up is the way we assess response. Our RECIST criteria are largely designed around chemotherapy type of responses. And for immune responses, they may not always completely apply and be able to help us make a decision about the actual response rate in the patient. Clearly, there are patients with stable disease or progressive disease who also tend to benefit occasionally, not as strongly as the ones with the objective response.
Yeah, it's interesting to point out, we've all seen patients like this in our clinic who have residual masses after they've been on therapy for a long, durable period of time, and they may undergo resection in an attempt to kind of make them NED or no evidence of disease on imaging. And you resect out this, maybe large, several centimeter tumor, or what you think may be a tumor, and it ends up being necrotic, all dead tissue. So I think, our response parameters don't really assess that very well. And I think people that do enter a deep remission, though they may not necessarily have a complete response, can still derive benefit. And I think some of that data was presented by Dr. Brian Rini from the mRCC trial at ASCO last year. And I think it's important to highlight the limitations of our current response assessment criteria.
So are there better response criteria, or, I know definitely radiomics is an up and coming translational correlative imaging technique that may be able to determine responses better or predict benefit to immune therapy. Is there any other criteria that anybody's using?
So in the cooperative groups, at least, there's been a very big push to use iRECIST criteria to think about what is true pseudoprogression versus not. And the confirmatory scan for progressive disease is very important for iRECIST criteria. We are currently incorporating these into our trials that incorporate immune checkpoint inhibitors, but I think these criteria still have to be validated.
Agreed. And maybe in these large cooperative group trials, we'll be able to validate iRECIST as a better response technique. But
yeah, and this may come a little bit later, but I completely agreed with some of the statements that were made at ASCO last year by the panel that was discussing that patients that have clear cell with sarcomatoid features tend to be the highest predictor of patients that really benefit in a major way from this combination, with a 60% response rate, close to 20% CR rate. So those patients in particular, which had been by far the worst off, are now clearly benefiting in a tremendous way from this approach.
yes, agreed.
And also, Ulka, I just want to point out another topic. Nowadays, we are in the era of advanced imaging. PD-1 PET scan is coming up, and I think this is very promising. Follow up the patient and see the pattern of resistancy and whether this is immune hot or immune cold location. I think knowing this by using advanced PET really gonna be very helpful for us to push the bar.
Yes, that's an excellent point. The new novel imaging techniques that will help us predict responses better are definitely, stay tuned for that.